can just talk. I'll adjust it for my height here, being a little shorter. So I'm really excited to be here and be able to share these results with you guys. I'm just so grateful, and thanks to Brian for this opportunity. So I'm going to be talking about the effectiveness of integrating suicide care and primary care, and we used a cluster randomized implementation trial design. Before I jump in, though, I just want to acknowledge that we could not have done this work without the people who both receive and provide care at Kaiser Permanente, Washington, and that's in Washington State, the West Coast. I also want to acknowledge that I'm definitely not doing this work alone. There's a huge number of people that have supported this work. We had support from Brian's grant. This picture is actually from a decision aid I'm going to come back to at the end. And I also want to acknowledge that I have some personal experiences with suicide loss. So pictured here is my mom, who died by suicide in 2010. And I share that because her loss really motivated me to do this work, and so I just really like to be clear about my motivation. She's pictured here with my daughter as a baby, but my daughter's much older. She's here with me in Liverpool now, and we're really excited to enjoy this amazing city. So I'm not going to make you wait to learn what we learned. Our key outcomes after integrating this mental health integration program in primary care, we increased safety planning by 15%, and we decreased suicide attempts by 25%. So it was a really amazing effort. Yeah, thank you. So next, I'm going to go back and tell you how we got there. So some of the things that we heard at the beginning before we launched this work was, whose idea was this? We don't have enough time or resources to do this. We're too overwhelmed. This is like opening up Pandora's box. But we started hearing different things at the end of the work. We heard things like, this is one of the best things that has happened in my primary care practice. This is just how we do primary care now. I wouldn't go back to providing care the way I used to if they asked me to. So I'm going to tell you next a little bit about what we implemented. So we implemented risk identification, screening. We had a 7-item screen that we used, focused on depression and substance use. Originally, this work was actually designed to focus on outcomes of integrating alcohol-related care, so we did actually have a real big focus on alcohol and other substance use. But leaders in our system asked us also to focus on suicide care and care for other drug use. I want to acknowledge that one of those leaders is in the room in the back, Tori Gildred, so thank you to Tori for her vision at that time. So we followed that up with a risk assessment for depression, suicide risk, and also substance use again. And then that was followed by prevention, shared decision-making, and treatment. So in the middle of that box, you can see a bullet for warm handoffs to integrated mental health specialists. Those were social workers who supported safety planning in our system, and that was really, really important. So I won't go through everything in these boxes, but you can see what we implemented. Next, I'm going to talk about how we implemented, just real briefly. We used these 3 strategies: practice coaching, clinical decision support, performance monitoring, and feedback. There's a lot more detail in the paper that's focused on alcohol-related outcomes that's already been published. These results that I'm sharing with you today have not yet been published, but we're really close. So hopefully you'll be able to see that in the published literature soon. So practice coaching, what that looked like. Coaches were really kind of the main link between the different parts of the project. So they were the main link to the clinical teams that were supporting this work in each one of the clinics, to our operational leaders, and also to different teams that were supporting the electronic health record tools that we developed, as well as the data team, so the metrics that we developed and the data that I'm going to be sharing with you today as well. Electronic medical record-based clinical decision support prompted everything that we implemented. So starting with adults, so this work was focused on adults coming into primary care at least once a year. We're receiving these screening instruments. And then there was additional prompts for risk assessment and safety planning when patients were reporting prior month intent or planning for suicide. And that's, like Brian mentioned, we used the Columbia to measure that. Performance monitoring and feedback looked a little like this towards the end. Each clinic received data monthly, so they could see, these are really focused on risk identification, but suicide risk assessment, you can see, is here in the middle. We used a pragmatic stepped wedge design, like I mentioned at the beginning, so there was 7 waves of clinics that rolled out. 25 clinics were included in our randomized trial, but we actually work was all piloted in 3 clinics first, and they really, the folks in those systems really helped us figure out what we were gonna be implementing. So the evaluation that I'm gonna show you in just a second compared people in the usual care period. So that was, that included this preparation phase when coaches were meeting with our clinical teams at each site for 2 months before we actually launched. Then there was a randomly assigned launch date, and then the intervention period included this time when the coaches continued to meet with our clinics for additional 4 months. So there was actually a lot happening in the clinics, both in the usual care and the intervention period. So our population that we included in the analysis, there were 255,000 patients with about 953,000 visits in the usual care period, 228,000, 615,000 visits. And we looked at the demographics of our patients in both the usual care period and the integrated mental health period, and they were pretty similar, so that's what we wanted to see. And again, there's a lot more that I could tell you about, but it's all in this paper and hopefully another one to come very soon. In terms of risk identification, there was a pretty big increase in screening for depression. So you can see these results are all per 10,000 patient visits, so it went from 2,900 to 8,200 per 10,000 patient visits, so that's a pretty big increase. But in terms of like the number of patients reporting suicidal intent or planning, that's on the Columbia, it was about a difference of about 10 per 10,000 patient visits. When we look at engagement and treatment, safety planning, I mentioned before, there was a big increase, so we were excited to see that. New psychotherapy was kind of interesting. It wasn't one of our main outcomes, but I included on this slide because we actually saw like a small but statistically significant decrease in new psychotherapy within 90 days, where we hypothesize that's because the clinical social workers working in primary care were actually meeting the needs of some of the patients, and so maybe they didn't need to go to mental health specialty after that. I don't know, but it's just something that we hypothesized. And then moving on to the results that we're really excited about, that I talked about at the beginning of my presentation. This is where we saw the 25% decrease in suicide attempts. So this is a combined measure of non-fatal and fatal suicide attempts within 90 days of a primary care visit. So we were really, really excited to see that result. So, quick recap. We implemented team-based primary care for substance use and suicide care. We used population-based screening and assessment. We had integrated mental health providers available for warm handoffs. We had some brief interventions, treatment initiation for substance use disorders, and also suicide risk mitigation via safety planning. The things that we're doing now, I just want to touch on really briefly because we're excited about it. There's a new focus on firearm suicide specifically because that's the #1 way that people die by suicide in the US. So we just launched a new program. This is a picture of step number 6 of our safety plan. We implemented Lock to Live, which is that decision aid. It's a web-based decision aid to help people make decisions about how to store firearms and prescription meds, so that's now just standard in our safety plan. And just last week, we actually rolled out a new program where we're making cable locks available to whoever wants them in our system. So providers can really simply order those, just like you would order any other procedure, have a cable lock sent to their patients. So we're excited about that work. And then finally, we're using predictive analytics. We've been doing that for a while now in mental health specialty to help support risk identification, but we're trying to figure out how to do that in primary care too. So that's some work that we're pretty excited about. So next I'm gonna turn it over to Jen. Thank you.